Okay, so today we're going to get into the critical subject of respiratory failure. This is a serious condition that can present in several forms, has significant implications for patient care. So let's just start by defining it. It's a syndrome in which the respiratory system fails in one or both of its gas exchange functions, either oxygenation or carbon dioxide elimination. This failure can lead to life threatening consequences and it requires immediate medical attention. Respiratory failure encompasses acute respiratory failure or ARF, acute respiratory distress syndrome ARDS, and severe acute respiratory syndrome or SARS. These sound really similar, but each condition has its own causes, symptoms, and care needs, and we're going to talk about these in detail throughout this presentation. And particularly for our older adult clients, understanding these conditions is crucial. As they age, individuals experience normal changes to their lungs, and these include decreased lung elasticity and thickening alveoli. These changes reduce their pulmonary reserves, and this can lead to quicker decompensation in the face of respiratory failure. Understanding the pathophysiology, the assessment, the risk factors, the nursing care, and the interprofessional care of these conditions is key to delivering effective patient centered care. So, right now, we're going to make sure we get you all the information you need to confidently manage these conditions in clinical practice. Let's start with acute respiratory failure or ARF. This is a condition characterized by the failure to adequately ventilate and or oxygenate. And ARF is just generally categorized into the two types, ventilatory failure and oxygenation failure. Ventilatory failure is typically due to a mechanical abnormality of the lungs or the chest wall, impaired muscle function, especially with the diaphragm, or a malfunction in the respiratory control center of the brain. And each of these factors can lead to ineffective gas exchange and carbon dioxide accumulation. And that's why this type of respiratory failure or ventilatory failure is caused hypercapnic respiratory failure because we have a buildup of carbon dioxide in the bloodstream. On the other hand, oxygenation failure can result from a lack of perfusion to the pulmonary capillary bed. And this can happen with, say, a pulmonary embolism or a condition that alters the gas exchange medium, like pulmonary edema or pneumonia. This leads to hypoxemic or oxygenation failure. And this is where oxygen levels in the blood are insufficient. Now, both inadequate ventilation and oxygenation can occur in clients who have diseased lungs, such as those with asthma, emphysema, cystic fibrosis. And in these cases, diseased lung tissue can cause oxygenation failure and increased work of breathing, which eventually leads to respiratory muscle fatigue and ventilatory failure. And when both types of failure are present, the hypoxemia or low oxygen levels in the blood can become even more profound. The criteria for diagnosing acute respiratory failure is based on arterial blood gas or ABG values, and we will discuss these more in more detail later in this presentation. And I do have an entire separate presentation for you just on diagnostic procedures. But you need to understand this pathophysiology so that you know how to develop effective nursing interventions and care plans. Now let's look at the pathophysiology of acute respiratory distress syndrome or ARDS. ARDS is a severe form of acute lung injury and is characterized by widespread inflammation in the lungs. The process usually begins with a significant injury or infection, which triggers an intense systemic inflammatory response. This response damages the alveolar capillary membrane and increases its permeability. As a result, fluid and proteins that normally stay within the capillaries leak out into the alveoli. And this is what we refer to as pulmonary edema. And this in turn leads to diminished gas exchange and hypoxemia. The buildup of fluid in the alveoli also reduces the production and function of surfactant, which is a substance that keeps the alveoli open. As the level of surfactant drops, alveoli can collapse or fill with fluid, and this exacerbates the pulmonary edema and worsens the hypoxemia. ARDS represents a significant challenge in critical care. It can develop quickly. It carries a high mortality rate, as high as 58%. Its causes are diverse, and they can range from direct lung injuries like pneumonia and aspiration to systemic events like sepsis or even trauma. It's important to note that ARDS is not a specific disease. It's a syndrome, and a syndrome is a collection of clinical signs and symptoms. And this syndrome is a collection of clinical signs and symptoms that are caused by a disease process that leads to a similar set of lung changes. It requires immediate and aggressive treatment, and understanding the pathophysiology is crucial when we're looking at our management strategies. Now let's look at severe acute respiratory syndrome or SARS. This is a viral respiratory illness caused by a coronavirus, and this is the same family of viruses that causes the common cold. But SARS is much more severe and potentially life-threatening. The SARS virus invades the pulmonary tissue, triggering an inflammatory response. This process is at the core of SARS pathophysiology. The body's immune response responds to the viral invasion, but is so robust that it ends up damaging the lung tissue, causing pneumonia or a more severe condition of ARDS. The virus is highly contagious. It's spread primarily through airborne droplets from sneezing, coughing, or talking, meaning it can be quickly transmitted in close contact situations. And it's important to note that SARS doesn't typically spread to the bloodstream because it thrives at temperatures slightly below the normal core body temperature, so it predominantly affects the respiratory tract. But this is not always the case, and in the SARS coronavirus 19 epidemic, we did see a lot of issues with coagulopathy, which are very unusual for a coronavirus. So SARS first gained global attention in the early 2000s during an outbreak that affected thousands of people worldwide with a high mortality rate. And more recently, other strains of coronaviruses have caused similar outbreaks, including the MERS coronavirus and the SARS coronavirus 2. And that's the virus that causes COVID-19 that is a little bit atypical for a coronavirus. Understanding the pathophysiology of SARS is important because it guides the development of prevention measures, diagnostic tests, treatments, and vaccines. So, we're going to go over risk factors and expected clinical findings in patients with SARS, which is going to help you with your nursing assessment to provide the care these patients need. So now let's talk about some expected findings in patients who are suffering from respiratory failure. And these are signs and symptoms that commonly present in these patients. Now, these are going to vary based on the underlying causes, the severity of the condition, and individual factors such as age and overall general health status. But some general signs to look out for include shortness of breath, dyspnea, which may occur with or without exertion. This may be accompanied by orthopnea, which is difficulty breathing while lying flat. Breathing may become rapid and shallow. These symptoms can be a reflection of the body's attempt to compensate for insufficient oxygen levels in the blood. The skin and mucous membranes may show signs of cyanosis, and this is a bluish discoloration indicating low levels of oxygen. There might also be a mottled or dusky appearance of the skin. You might notice tachycardia or a rapid heartbeat as the heart tries to compensate for the lack of oxygen. Hypotension or low blood pressure can also occur. Chest retraction, specifically substernal or suprasternal chest retractions, can be observed. These are signs of an increased effort being required for the patient to breathe. A decrease in blood oxygen saturation, or SaO2, less than 90% is commonly seen. Adventitious breath sounds, including wheezing or rales, may be heard upon auscultation of the lungs, and this indicates respiratory distress or fluid buildup. Cardiac arrhythmias or irregular heart rhythms can occur due to the heart's response to low oxygen levels. Moreover, confusion and lethargy may present due to the brain's sensitivity to oxygen deprivation. In acute respiratory failure, or ARF, we may see signs like dyspnea, orthopnea, cyanosis, pallor, and hypoxemia, and we're going to see low levels of oxygen in the blood. The patient may exhibit signs of irritability, agitation, and restlessness, and they may have hypercarbia, which is a high level of carbon dioxide in the blood. For patients with acute respiratory distress syndrome or ARDS, dyspnea is common along with bilateral non-cardiogenic pulmonary edema. So that's pulmonary edema not caused by issues with the heart. And this is evidenced by crackles upon auscultation. There is reduced lung compliance and severe hypoxemia despite administration of 100% oxygen. So we need to know to recognize these expected findings in respiratory failure so that we can provide appropriate and timely care to our patients. An essential part of the clinical evaluation of patients suspected of having respiratory failure is to conduct a series of laboratory tests and diagnostic procedures. These not only help to confirm the diagnosis, but give us valuable information about the severity of the condition, guide our treatment choices, and monitor the effectiveness of interventions. So we're going to start with blood tests. An arterial blood gas or ABG analysis is often the first step, and this gives us insight into the patient's blood pH, partial pressure of oxygen, partial pressure of carbon dioxide, bicarbonate levels, and oxygen saturation. This is crucial in evaluating a patient's gas exchange capability and acid-base balance. A complete blood count might be taken to check for signs of infection or anemia, which could contribute to respiratory failure. Elevated white blood cells, for instance, might indicate an ongoing infection. Another useful test is serum electrolytes or renal function tests. These can give us a picture of the patient's hydration status and kidney function, and this could be compromised in severe cases of respiratory failure. We should also consider specific biomarkers like a B type natriuretic peptide or BNP, or an N-terminal pro-B-type natriuretic peptide, which is the NT-proBNP, for differentiating between respiratory and cardiac causes of dyspnea. Moving on to diagnostic imaging, a chest x-ray is usually one of the first-line diagnostic tools to visualize lung conditions such as pneumonia, pulmonary edema, or pneumothorax, and that might be causing or contributing to respiratory failure. Computed tomography or CT scans provide more detailed images and can help to identify other issues such as pulmonary embolism or advanced lung diseases not evident on a simple X-ray. Pulmonary function tests can be helpful in assessing lung capacity and the efficiency of gas exchange. These tests measure various aspects like forced vital capacity, forced expiratory volume in 1 second, and the forced expiratory volume in 1 second to forced vital capacity ratio. Lastly, bronchoscopy can be used in certain cases where more direct visualization, possibly tissue sampling from the bronchi or lungs, are needed, such as if we have a suspected malignancy. So, laboratory tests and diagnostic procedures do play a key role in managing respiratory failure because they're going to help us formulate a comprehensive treatment plan that's tailored to the patient's unique condition, and they help us to track the progression and response to treatment. So, always remember to consider these in the context of the patient's clinical history and physical exam findings. Nursing care is a critical component in the treatment and management of patients experiencing respiratory failure. The interventions that we take as nurses not only improve patients' clinical outcomes, but also enhance their comfort and quality of life. So, our initial focus needs to be on maintaining a patent airway and optimizing oxygenation and ventilation. These involve administration of supplemental oxygen through various devices, ranging from a simple nasal cannula to more advanced non invasive or even invasive mechanical ventilation, depending on the patient's needs. Patient positioning can make a significant difference. For instance, promoting a semi-Fowler's or high Fowler's position can facilitate better lung expansion and gas exchange, while prone positioning might be utilized in severe cases of ARDS to improve oxygenation. Regular monitoring of vital signs, including heart rate, blood pressure, respiratory rate, oxygen saturation, and signs of respiratory distress, is crucial. Be vigilant for any changes in these parameters as they could indicate worsening of the patient's condition. Pulmonary hygiene interventions such as chest physiotherapy, incentive spirometry, and frequent suctioning for patients unable to clear their secretions should be part of routine care. These techniques help to clear mucus from the airways and improve lung function, and they reduce the risk of infections. A critical aspect of nursing care is medication administration and management. This may include bronchodilators, corticosteroids, antibiotics, diuretics, or other medications as prescribed by the physician. Ensure correct dosing and monitor for any potential side effects. Proper nutrition and hydration support are essential as well. Patients with respiratory failure may have increased metabolic demands and they may struggle with eating due to breathlessness. Collaborate with a dietitian if possible to develop a nutrition plan that addresses these challenges. And depending on how serious the condition becomes, they might need to receive parenteral nutrition instead of oral nutrition. Pain and anxiety management is another crucial component. Respiratory distress can cause significant anxiety, and this in turn can exacerbate the distress. Use of analgesics, anxiolytics, and non pharmacologic techniques such as relaxation and distraction can be beneficial. Finally, communication and patient education are vital. Ensure that patients and their families understand the nature of their condition, the treatment plan, and any self care activities they need to perform. Empowering them with knowledge can gain additional compliance and lead to better outcomes. Interprofessional care is a cornerstone of successful patient outcomes, especially in complex health situations like respiratory failure. So, the patient's primary physician plays a crucial role. They diagnose respiratory failure, prescribing appropriate medication and treatment plans, and making necessary referrals to specialists if required. The role of the pulmonologist is vital in managing respiratory failure. These are physicians who have specialized knowledge and skills to provide advanced respiratory treatments and management. They can guide the team regarding ventilator management, bronchoscopic procedures, and lung function optimization. Intensivists also play a key role, especially in cases of acute respiratory failure or ARDS, which often requires intensive care unit admission. Their expertise in critical care medicine helps to manage severe and life threatening conditions. We nurses are always the frontline caregivers. We monitor the patient's health status, administer medications, provide emotional support, and educate the patient and their family. We play a crucial role in assessing the effectiveness of the treatment plan and communicating changes in the patient's condition to the rest of the team. Respiratory therapists are experts in managing respiratory equipment and treatments, including ventilators, oxygen therapy, and airway clearance techniques. Their expertise is invaluable in these cases. Physical therapists might help with chest physiotherapy and mobility exercises, and these are essential for patients to prevent muscle wasting and facilitate lung expansion. Dietitians ensure that patients receive appropriate nutrition to cope with increased metabolic demands and recovery. They customize meal plans considering the patient's specific needs and limitations, and they might help us to calculate what's needed for our TPN. Pharmacists ensure the safe and effective use of medications, provide information about drug interactions, side effects, and monitor for drug efficacy. Social workers and psychologists provide emotional support, help with coping strategies, and can assist with social and financial issues related to the illness. The contribution of every team member is essential for achieving the best possible outcomes. Now let's talk about some possible complications and preventive measures for respiratory failure. Respiratory failure can lead to a whole cascade of complications due to reduced oxygen and increased carbon dioxide in the body. The most immediate risk is that vital organs like the heart and brain may not receive adequate oxygen, leading to conditions such as arrhythmias, myocardial infarction, stroke, or even organ failure. Other complications include respiratory acidosis, atelectasis, pneumothorax, pulmonary embolism, and ventilator associated pneumonia. Long-term complications can also occur. If a patient is on a ventilator for a prolonged period of time, they may experience ventilator-associated lung injury, also called barotrauma. Muscle weakness and cognitive changes are also possible, particularly in ICU settings, known as post-intensive care syndrome. We're going to have to watch out for these things. Now, moving to preventive measures. The most effective prevention for respiratory failure is to manage the underlying conditions that increase the risk. This includes proper management of chronic diseases like COPD, asthma, heart disease, and diabetes. Regular checkups and timely medications can help in maintaining control over these conditions. Smoking cessation is crucial as smoking can damage the lungs and lead to chronic respiratory diseases. Education about the hazards of smoking and smoking cessation programs can help with this regard. Infection control is also essential, especially in hospital settings. Hand hygiene, appropriate use of PPE, and infection control protocols can reduce the incidence of hospital-acquired infections leading to respiratory failure. For patients at risk, vaccination against respiratory pathogens like influenza and pneumococcus is very recommended. Early mobilization and respiratory physiotherapy can also help prevent complications like atelectasis and muscle weakness in hospitalized patients. And finally, it's essential to recognize and treat symptoms of respiratory distress promptly. Delay in treatment can lead to worsening of the condition and potential respiratory failure. So we have to know how to manage respiratory failure, and it involves vigilance and being really proactive, both in treating the condition and in preventing any complications. Patient education, of course, is a critical component of care. It helps to enhance adherence to treatment plans, preventive measures, and contributes to better patient outcomes. So let's look at the main areas we need to focus on in patient education. Patients need to understand what respiratory failure is, why they are at risk for respiratory failure, and how the condition can be managed. Explain the importance of oxygen therapy, ventilatory support, and medications in simple, non-medical terms. Discuss the importance of regular follow-ups and health checks to monitor their condition. Educate patients on early signs of worsening respiratory status like increased breathlessness, changes in sputum color, increased cough, and decreased exercise tolerance. Make sure they know that immediate medical attention is required if these signs occur. Understanding the importance of medications is crucial. Make sure that patients understand why each medication is necessary, how to take it, and how to watch for any potential side effects. Discuss the importance of smoking cessation, regular exercise, a balanced diet, and maintaining a healthy weight. Each of these lifestyle modifications can significantly contribute to improved respiratory health. Teach patients about the breathing techniques that can help during episodes of shortness of breath, such as pursed lip breathing or diaphragmatic breathing. If available, recommend pulmonary rehabilitation, which includes exercises and education designed to improve respiratory health. Talk about the importance of vaccines, such as the flu vaccine and the pneumococcal vaccine, in preventing respiratory infections. Discuss the need for good hand hygiene and avoiding exposure to respiratory irritants like dust and fumes. And acknowledge the emotional and mental health aspects of living with a chronic respiratory condition. Encourage patients to express their feelings, fears, or concerns. Point them towards support groups, counselors, or mental health professionals if necessary. If we have an acute situation and a patient who is on a ventilator, the family is going to need this support. Remember that patient education should be individualized based on the patient's needs, understanding, and readiness to learn, and it has to be an ongoing process. This is not a one time event. Health promotion and disease prevention play a significant role in managing and preventing respiratory failure. We need to empower individuals to make healthy choices and equip communities to provide supportive environments. So let's discuss some crucial points. Smoking is the leading cause of preventable disease and death, significantly contributing to respiratory conditions. All health promotion efforts should encourage smoking cessation, provide resources and support for those trying to quit, and aim for strict enforcement of tobacco control policies. Regular physical activity can improve lung function and overall health. Encourage individuals to engage in at least 30 minutes of moderate intensity activity most days of the week. A balanced diet plays a critical role in maintaining overall health and managing chronic diseases. We need to promote the intake of fruits, vegetables, lean proteins, and whole grains while reducing processed and fast foods. Air pollution, both indoor and outdoor, is a significant risk factor for respiratory diseases. Promoting the use of cleaner fuels, ensuring proper ventilation, and reducing exposure to pollutants are all important. Encourage regular vaccination against respiratory infections like influenza and pneumococcal disease. For those at high risk, these vaccines can significantly reduce the risk of acute respiratory illnesses. Regular health screenings can help to detect diseases early when they're most treatable. Encourage regular checkups, especially for those with a high risk of respiratory diseases. Provide comprehensive education about the risk factors and symptoms of respiratory diseases. Advocate for policies that promote respiratory health, like stricter air quality standards and better access to healthcare services. Chronic respiratory conditions often come with significant mental health challenges. Promote mental well being through regular social interaction, stress management techniques, and access to mental health services when needed. Health promotion and disease prevention are not only the responsibility of healthcare providers, but they're really the responsibility of society as a whole. But we need to work together and lead the way in creating environments that promote respiratory health and prevent disease. Let's look at some priority problems, aka nursing diagnoses, that might be appropriate for your patient. Remember, you need to look at the evidence for your particular patient, and these must be customized. These are not one size fits all or cookie cutter. They're just to give you some ideas. So let's start with we may have impaired gas exchange. So we're going to want to monitor vital signs and oxygen levels, observe for signs of hypoxia and respiratory distress. We'll administer any oxygen therapy as ordered and position the patient for optimal ventilation. And then we'll explain the importance of deep breathing exercises, instruct the patient about monitoring their own oxygen saturation levels. Maybe we're concerned about ineffective airway clearance. In that case, we're going to listen to lung sounds, evaluate the patient's effectiveness of their coughing and any sputum production, administer bronchodilators and mucolytics as ordered, and perform chest physiotherapy. And we may instruct the patient on effective coughing and deep breathing techniques and educate them on the use of any prescribed inhalers or nebulizers. If we're worried about activity intolerance, we may monitor the patient's ability to perform daily activities, check for signs of fatigue and dyspnea, and provide assistance with daily activities while planning for periods of rest. We're going to teach the patient energy conservation techniques and educate them about the importance of regular, gradual physical activity. Remember always to customize any of your nursing priority problems or any of your interventions for your specific patient. So let's wrap up and take a minute to reflect on the critical role that we play as nurses in the management of respiratory failure. Whether it's acute respiratory failure, acute respiratory distress syndrome, or SARS, our understanding of these conditions and our care can make a life changing difference for our patients. We've looked at pathophysiology and looked at the need for early detection through recognizing risk factors and expected findings. We've looked at some various diagnostic procedures and laboratory tests that can help us to understand the patient's condition more accurately, and we've looked at how these guide our nursing care. Please do check out the specific video on these topics. We've looked at the the role of interprofessional care from respiratory therapists to dietitians and reminded you that every member of the healthcare team has a contribution to make. And we talked about prevention and education. Remember that various nursing diagnoses we encounter in patients with respiratory failure need to be customized for your patient, and our work does not stop at direct care. We need to equip our patients with the right information and skills for managing their condition.